Welcome to an overview of my final chapter, and that's Chapter 8, or Dynamic Means of Cardiovascular Monitoring. So what we're trying to get at with dynamic means of cardiovascular monitoring is determining whether somebody is volume responsive. And what I want to talk about in this slide is the difference between volume responsive and volume status, which people seem to use interchangeably and inappropriately. So if you increase your right atrial pressure, and that results in an increase in output, then you are volume responsive. So in this patient, I've sort of delineated in this green area that if they're on this portion of their Starling curve, increasing their right atrial pressure by, say, increasing their venous return, will augment blood flow. And in this portion in red here, this is the flat portion of the Starling curve. Giving more fluid on the flat portion here will not augment blood flow and only increase filling pressure with likely detrimental outcomes. So how do we know when the patient is on the ascending portion of the curve? Because you can have a patient like this one who, with their venous return curve shifted leftward, this patient could actually be hypovolemic, but they're actually operating on the flat portion of their cardiac function curve because of their diminished cardiac function. So this patient could be hypovolemic but volume not responsive. So you can see that there can be a considerable distinction between volume responsiveness and volume status. So how do we pick out, or how do we determine, or how do we assay the patient's preload reserve? That is, how much more preload can they tolerate with an increase in their forward flow? So we do this through this via this phenomenon that I think was coined by Mike Pinsky, and that is functional hemodynamic monitoring. So we apply some stress to the cardiovascular system, and in many cases it's a change in intrathoracic pressure, and then what we measure is a response. And these responses can be things like left ventricular stroke volume variation or changes in vena cava diameter. And you have to sort of think of this as like being similar to pharmacology, in that you must standardize the stress or dose, and that if you have non-standardized stresses or doses, the outcome will vary. And you don't know if the outcome is varying because there's something inherently different with the system, or if it's just because you're giving a different dose. And this is a true problem because these patients who, for which dynamic parameters like pulse pressure variation have been derived, they were a very specifically chosen group of patients with very specific baseline cardiopulmonary physiologies. And once you start to deviate away from that, the responses that you measure may reflect volume responsiveness, or they may actually not. And that's essentially what I'm saying there. So let's talk about the difference between systolic pressure versus pulse pressure variation. So this is the arterial blood pressure tracing. This is your airway pressure tracing, say off the ventilator. You give a breath after an apneic baseline, and this is your systolic pressure maximum. This is your systolic pressure minimum, and this is your D up, and this is your D down, or delta up and delta down. And this leads to a variation in the arterial waveform. Conversely, you can measure the pulse pressure, which is the systolic less the diastolic pressure for the maximum the waveform with the maximal pulse pressure, and compare it to the waveform with the minimum pulse pressure, and this determines your pulse pressure variation. And the pulse pressure is essentially a direct surrogate of stroke volume, because the systolic and diastolic pressure will change as a function of the left ventricular stroke volume. Importantly, it's not the airway pressure that's driving these changes. It's the airway pressure causing the lungs to expand against the chest wall, and driving an increase in intrathoracic pressure that drives these changes. So let's talk a little bit about the mechanisms of this respiratory variation in arterial blood pressure. So back to the apneic baseline. What is the determination of this D down phenomenon? Certainly, there's multiple causes of the D up, but the more important aspect is this D down, and why it's more important I talk much more about in Chapter 8. But essentially, the D down reflects a delayed response of right ventricular output. So this response, although it's occurring during expiration, it's being measured during expiration, this is actually an inspiratory event. And so why is that? Well, the mechanism of D down follows as such. This is your right ventricular cardiac function curve and your systemic venous return curve. As you increase the intrathoracic pressure in a patient who is like the patients in which these parameters were derived, this patient is heavily sedated, potentially paralyzed, and receiving at least 8 cc's per kilogram of tidal volume ventilation. You increase your intrathoracic pressure, and you've actually decreased your cardiac output during inspiration from here to here. That was during inspiration. 2 to 3 heartbeats later, during expiration, this is reflected across the pulmonary vascular bed as reduced venous return. So this is your left ventricular cardiac function curve. This was the D up that just occurred during inspiration. So during expiration, the diminished RV output from inspiration reaches the left ventricle, reduces pulmonary venous return, and drops the output. The decreasing intrathoracic pressure that also occurs with expiration tends to distend the RV as the RV is charged with blood during expiration on mechanical ventilation, and it tends to mildly increase your left ventricular afterload. So that may slightly increase the degree of D down, but in a heart with a normal Starling curve, those effects are minimal. It's much more, the D down is much more driven by the previous inspiratory diminution in right ventricular output. Then I want to talk about some caveats in left ventricular output. Dynamic left ventricular output as a marker of fluid responsiveness in the mechanically ventilated patient. And this left ventricular output, again, is essentially dynamic changes in left ventricular stroke volume and surrogates thereof, so pulse pressure variation, systolic pressure variation, changes in descending aorta flow, changes in aortic outflow tract VTI. These are all measurements of essentially the same thing. So talking a little bit about stroke volume variation specificity. So specificity, again, determines false positives. So both the D up, or maximal pulse pressure, and the D down, or minimal pulse pressure, may change from respiratory variation in cardiac physiology that does not reflect preload responsiveness. And by understanding the Guyton analysis, you can see that left ventricular output can vary as a function of altered compliance, say by ventricular interdependence, and by afterload from both ventricles, actually. If you increased right ventricular afterload, you will have a diminished, a few beats later, you'll have a diminished left ventricular output, but that's not because the right ventricle was volume responsive, that's because the right ventricle was actually afterloaded inappropriately. Or similarly, direct afterloading of the left ventricle will impair its output. So these will diminish the specificity of left ventricular stroke volume variation or pulse pressure variation. And these changes in afterload and compliance, and that compliance, I mean ventricular compliance, are more likely to result in false positive pressure, or false positive pulse and stroke volume variation when the ventricles are sensitive to afterload. And this is particularly true in heart failure states. And it is exacerbated when intrathoracic pressure is excessively high, because the dose or the stress that you're applying to the cardiovascular system in this situation will be markedly higher than they were in the derivation group. And this would be true if very high tidal volumes are used or low chest wall compliance is encountered. So this would be a false positive. I call it facilitation of D up. And so again, your apneic baseline, this is your delta up. So the mechanisms of increased D up are the result of direct transmission from intrathoracic pressure. Decreased left ventricular afterload will facilitate D up. Improved left ventricular compliance, say from ventricular interdependence. If you shrink the right ventricular cavity, you'll then allow the left ventricle to preload more and therefore increase its output. An increased pulmonary venous return. So if the lungs are under excessive amounts of West Zone 3 physiology and you give that patient a breath, well then more blood will be squeezed out of those lungs, and that may facilitate D-up physiology. And again, you can understand how all of these would be augmented in heart failure states. And in heart failure states, particularly if there's a high intrathoracic pressure, because it's the intrathoracic pressure that really determines how and to what degree the right ventricle shrinks during a mechanical inspiration, which would facilitate left ventricular filling. The change in intrathoracic pressure will also determine to what degree the left ventricle is afterloaded, which will facilitate left ventricular output in a clinical state that should not be marked by fluid responsiveness, or the patient should not be administered fluids. So this is the balloon in the box analogy. These are 3 different lungs, and they're all getting the same tidal volume from this hokey machine. This is a normal chest wall is the box, lung is the balloon. Okay, normal, normal, normal. This is normal lung, stiff chest wall, so obesity, massive ascites. And this is stiff lung, normal chest wall. So this is like classically really bad pulmonary ARDS. The pressure, the intrathoracic pressure or the pleural pressure, will be the pressure that is generated between the two as the lungs move out and expand and push into the chest wall during a completely passive mechanical breath. So you give all of these patients the same volume. Well, watch what happens to the normal lung. The volume of the balloon will increase. It will press out against the chest wall. The chest wall, it will increase, and you'll get a pressure between the two, and we'll call that your baseline increase in intrathoracic pressure. Well, what do you think is going to happen in this situation? Decreased chest wall compliance. The lung will increase, but the chest wall will not move nearly as much, and there will be a greater pressure generated. The intrathoracic pressure or pleural pressure in this situation will be much augmented. And then conversely, what do you think is going to happen in this situation? Well, the lungs will expand minimally because they're very poorly compliant, and therefore they will not press out against the chest wall. And it doesn't really matter what the chest wall compliance is here. The pleural pressure will not be nearly as affected by this volume because of the impaired pulmonary compliance. So on this ventilator, you'll read a high driving pressure, so there'll be high peaks and high plateaus. Specifically, there'll be high plateaus with a high intrathoracic or pleural pressure. In this situation, there will be high plateau pressures, but the transpulmonary pressure will be high. And the transpulmonary pressure is the pressure in the lung or the alveolus less the pleural pressure. And you can sort of appreciate why that is from that diagram. So in this state, in the state of a poor chest wall compliance, when intrathoracic pressure is going up out of proportion to the same volume administered, this is going to have a much more profound hemodynamic effect on both ventricles in terms of their preload and afterload, and will become particularly prominent in patients with, say, biventricular failure. So both of these patients, in this one patient, both ventricles are operating on the flat portion of the Starling curve, and we'll say they're hypervolemic because their venous return curves are shifted out and to the right. Well, what happens if this patient has very poor chest wall compliance because they also have massive ascites, and you give them a breath? Well, there'll be an augmented increase in intrathoracic pressure. So what happens is you afterload the LV. So the left ventricular cardiac function curves moves up and to the left from that afterload reduction, from that high intrathoracic pressure, and then you with that increasing intrathoracic pressure, you increase left ventricular output from the lower afterload, and this facilitates D-up physiology. Simultaneously, the increased intrathoracic pressure causes the right ventricle cavity to shrink. You decrease the transmural or distending pressure, so the right ventricle shrinks in size from the increase in intrathoracic pressure, and that improves left ventricular compliance. And this is all occurring during mechanical inspiration in the passive patient. So you've augmented cardiac output to a greater extent. Remember, this is all D-up during inspiration. The increase in lung volume tends to increase pulmonary venous return as a function of West Zone 3 physiology. Well, guess what? You shift pulmonary venous return rightwards. So you actually, not only are you lowering left ventricular afterload, improving its compliance, you're also giving it more preload. So you can see that this patient will have a D up. Okay, but this patient, as we started at the beginning of the thought experiment, is not fluid responsive. So you may see a physiology like this in an overloaded patient. If this is the apneic baseline, they may have a D up, but they'll have minimal, if any, D down, because there really is not a decrease in their right ventricular output during the inspiration, which is then reflected later during expiration as a D down. Although there are caveats to that as well. Certainly if the patient has high right ventricular afterload from bad pulmonary hypertension or profound ARDS, and the breath actually increases transpulmonary pressure, and because of the increase in right ventricular afterload during inspiration, there's a diminution in right ventricular output, and that is reflected as a decreased preload to the left ventricle during expiration, 2 to 3 cardiac cycles later. You may actually get a D down in that patient, and then you're going to be in big trouble. You're going to think that patient is volume responsive, and they are not. It becomes exceptionally confusing when the patient is making inspiratory efforts during mechanical ventilation. So as opposed to the patient who is fully adapted with the ventilator, the patient making inspiratory and expiratory efforts profoundly confounds intrathoracic pressure variation, as you can imagine. If the patient is initiating the breath with a negative intrathoracic maneuver, their intrathoracic pressure will drop quite profoundly, and then as the ventilator applies the breath, if the patient sort of becomes passive with the ventilator, then intrathoracic pressure will rise. And this patient is still subjected to all of the same caveats like we just talked about, particularly patients who are in heart failure states who are very sensitive to changes in ventricular compliance and afterload. And then superimposed on that, you have this varying intrathoracic pressure, which will change your inspiratory D up versus D down and expiratory D down versus D up. So this has been shown in a number of papers to severely impair the sensitivity and specificity of pulse pressure variation as a surrogate for volume responsiveness. So this is the patient who's passively mechanically ventilated, as we just talked about. This is the apneic baseline. This is the patient who's breathing perfectly spontaneously. And if this is inspiration, actually during mechanical ventilation you get a D up physiology, but during spontaneous inspiration you actually get D down physiology. So if this patient's on the ventilator and they inspire by both negative intrathoracic pressure and then allowing the ventilator to do the trick, is it dominated by D down? Is it D up? Do they wash each other out? Do you initially get D down followed by a D up that gives you a spurious pulse pressure variation? It just becomes too complicated and too confounded to be truly reliable, and this has been borne out empirically as well. And then during expiration, similarly, you can variably get a D up in the spontaneously breathing patient, and then you can get a D, tend to get a D down in a patient who's passively mechanically ventilated. But knowing which one is which is very difficult, if not impossible. So I want to leave you with this example as we move away from pulse pressure variation in this overview of a patient with underlying alcoholic cardiomyopathy and cirrhosis. There's an aspiration event during a withdrawal seizure, and he's developing profound ARDS. So this is not an uncommon patient in an intensive care unit. The patient is intubated and sedated, but because of his alcoholism, even large doses of benzos and opiates do not adapt him with the ventilator. So he's still making fairly profound inspiratory and expiratory efforts. He's got large ascites and he's febrile. So again, this is the marriage of the Campbell analysis and the Guyton analysis. This is a normal patient, okay, with a normal pulmonary elastance and a normal chest wall elastance on the Campbell analysis. On the z-axis is thoracic volume going into the page. On the x-axis is intrathoracic pressure, as it is depicted on the Campbell diagram. So in this patient, as I said, he had ARDS, so his pulmonary elastance is impaired. The elastance is actually gone up, which is the same as saying compliance is decreased. And similarly, his massive ascites has increased his chest wall elastance, i.e. decreased his chest wall compliance. Okay, FRC is dropped. You dial in a lower tidal volume because of his ARDS. This is the tidal volume you're dialing in. So you dial in a little bit of a lower number, 6 cc's per kilogram, say. And now when you give this patient a breath, intrathoracic pressure or pleural pressure follows the chest wall elastance curve in a patient who is perfectly adapted with the ventilator. When the patient is perfectly adapted with a ventilator, it's like the balloon in the box analogy. The balloon or the lung is inflated by the ventilator, which pushes out against the chest wall, which then creates an intrathoracic pressure between the lung and the chest wall, and it will follow the stiffness of the chest wall. If you were to be interested in what would happen to the airway pressure during this breath, this is the elastance curve for the respiratory system. So this is sort of a summative curve for both the lung and the chest wall. It's actually, if you're interested, it's in chapter 1, but it's related, the difference in pressure between the pulmonary elastance and chest wall elastance curve for every volume is actually reflected as an airway pressure for volume in the elastance curve of the respiratory system. So this is essentially just a there's just a bunch of plateau pressures. So this is what the patient's plateau pressure would do during an inspiration. It goes way up because of the impaired respiratory system compliance. And now let's superimpose the Guyton analysis. Well, this patient may initially generate an inspiratory effort because he's not adequately sedated. And what will that do? Well, it will shift your... So first of all, let's say at baseline, this patient is not volume responsive. They may be hypervolemic because their venous return curve is shifted. They're on the flat portion of the right ventricular function curve. You do not want to give this patient fluid. Okay. The patient inspires, which would loosely follow the pulmonary elastance curve. The drop in intrathoracic pressure is tracked by the right ventricular cardiac function curve, but there is an increase in afterload because of the increase in transpulmonary pressure that you get with severe ARDS. That afterloads the right ventricle, so that further impairs right ventricular output and leads to a dramatic increase in the distending pressure of the right ventricle. This right ventricle distends, or right atrium, right ventricle will have the same distending pressure barring any tricuspid abnormalities. This increase in distending pressure then impairs left ventricular output by ventricular interdependence, and you may actually get a D-down physiology initially. Further, the drop in intrathoracic pressure will afterload the left ventricle, so immediately you may get a facilitated D-down physiology. If the patient then relents and lets the ventilator do its thing, well, an intrathoracic pressure will tend to rise along the chest wall compliance curve, though not exactly, depending on how active the patient is in terms of their muscles of inspiration and expiration. But the increase in intrathoracic pressure will shrink the right ventricular cavity. Okay, it may actually afterload reduce the left ventricle, and so to the extent that it improves the LV filling by ventricular interdependence and LV afterload is reduced, the terminal portion of this ventilatory inspiration may actually display a D up. So you may actually see this physiology during the course of an inspiration on this patient, but it doesn't, and if you just looked at this and accepted these numbers blindly, you'd say, well, this patient's volume responsive, but they're clearly not. So that was my clinical scenario. So a couple more things. In Chapter 8, I'm going to talk a little bit about assessment of the vena cava. I talk about the superior vena cava and the inferior vena cava, both assessment during passive mechanical ventilation and in the patient who's generating inspiratory efforts. And before I move on, I just want to make something very clear about this physiology. During a passive mechanical ventilation, during a passive mechanical inspiration, I should say, the patient is heavily sedated or paralyzed or potentially paralyzed. The superior vena cava will collapse. The inferior vena cava will dilate. Okay, say that again. During a completely passive mechanical inspiration, the superior vena cava will tend to collapse, and the inferior vena cava will tend to dilate. Okay, and I go through the physiology of that in Chapter 8. During a spontaneous inspiration, the inferior vena cava will tend to collapse. And the reason during a spontaneous inspiration that the inferior vena cava tends to collapse is a function of two things. Firstly, a falling right atrial pressure, and that's dependent upon three simultaneously occurring events, and that is a drop in pleural pressure, the degree to which the pleural pressure drops, the change in the venous return curve, which may occur with inspiration, and the change in the right ventricular cardiac function curve, which may occur with inspiration. Simultaneously, it means that abdominal pressure is increased, and this is a function of change in abdominal volume and change in your abdominal compliance. And again, this can be altered by the method by which patients breathe. If you teach patients to breathe with their intercostals as opposed to their diaphragm, they may not actually get any or minimal change in their abdominal volume, and so there may be minimal change in their abdominal pressure, and you can actually alter inferior vena collapse just by breathing differently. And again, that is not saying anything about changes in right atrial pressure or abdominal pressure. So based on this physiology, a rough correlation between right atrial pressure and IVC collapse has been determined in healthy patients without pre-existing heart disease, abdominal abnormalities, and with calm inspiratory efforts. This physiology has been exploited to show that the inferior vena cava collapse can be used to track changes in the right atrial pressure in patients undergoing dialysis. It cannot be used to determine a patient's absolute volume status, nor is it an adequate predictor of volume responsiveness. So what is the physiology of IVC collapse? So let's talk a little bit about the Guyton curve again. This is your right atrial pressure on the x-axis. This y-axis marks 0 or atmospheric pressure. The pressure above is above atmospheric pressure, and the pressure below is clearly below atmospheric pressure. So the important physiology to understand here is what is causing IVC, partially the IVC to collapse. Well, the IVC collapses when the pressure within the IVC drops below the pressure outside of the IVC, while the pressure inside of the IVC is determined by the right atrial pressure. The pressure outside of the IVC is determined by the abdominal pressure, and there has to be a transmural pressure gradient of at least 5 centimeters of water to see collapse of the abdominal IVC, because that's what you're looking at with the ultrasound. So where does that normally occur? Well, it normally occurs at roughly atmospheric pressure, or 0. This is our goalpost here. And the reason it normally occurs at atmospheric pressure is because the intrathoracic pressure tends to be just below atmospheric pressure. Did I say that right? The intrathoracic pressure tends to be slightly subatmospheric, and the abdominal pressure tends to be slightly atmospheric or a little bit above atmospheric. So when the right atrial pressure drops below 0 or atmospheric pressure, you get to the situation where the pressure within the IVC is below pressure outside of the IVC, and you get collapse, and it causes this plateau effect of the IVC, or this plateau effect of the venous return curve, and you see the fluttering IVC. It collapses and opens and collapses and opens. This the collapse of the IVC does not cease flow, it just causes the plateauing of the flow, because as the IVC collapses, as the abdominal pressure supersedes IVC pressure, the mean systemic pressure then instantaneously supersedes the intraluminal pressure, and it snaps back open again, and then it collapses and it snaps back open. So it's this fluttering effect that causes this maximal venous return. So in healthy volunteers with a normal inspiratory effort, collapse of the IVC greater than 50% served as an accurate surrogate of a CVP less than 10. So when this patient breathes in, the intrathoracic pressure drops from here to here, wherever it ends. The right atrial pressure drops as a function of the venous return curve and the cardiac function curve. And when the right atrial pressure drops below, significantly below atmospheric pressure, that is essentially a surrogate for the abdominal pressure raising above atmospheric pressure and collapsing the IVC. So you see collapse. And that's what you see in this little cartoon here. There's increased blood flow, and the abdominal pressure supersedes IVC pressure, and you get collapse at this plateau. If I were to take the same patient, give them a few liters of crystalloid, expand their volume status, increase their mean systemic pressure, increase their venous return curve, increase their CVP as a result, and they have the same cardiac function curve, and tell them to take the same, make the same inspiratory effort, well, they don't. Their right atrial pressure drops, but they don't quite drop below atmospheric pressure, and therefore you do not see this fluttering effect of the IVC. So saying that again, in this patient, say here the right atrial pressure at end expiration is, we'll just say for argument's sake, 10. They make an inspiration. They make an inspiration. They drop the right atrial pressure here to say 2, but it's not quite enough to cause abdominal pressure to supersede the intraluminal pressure. So there's actually, even though the right atrial pressure is decreasing, there's no significant right atrial collapse, or there might be just a smidgen of right atrial collapse as you approach this curvature here. So you can see that the inspiratory value of the right atrial pressure is affected by how deep they inspire, the shape of the venous return curve, which may change and actually does change with inspiration. I've simplified it a little bit. Usually when you inspire, the venous return curve instantaneously shifts rightward, and you may actually drop the resistance to venous return a little. And it's also determined by the simultaneous changing of the cardiac function curve, and I've simplified it again as well. Usually when you inspire, you may have a little bit of increase of the right ventricular afterload as your lung volume moves above functional residual capacity. Okay, so consider the following dialysis patient with a normal cardiac function curve and normal consistent inspiratory efforts without elevated intra-abdominal pressure. So this patient comes in for the dialysis session. They've got high intravascular volume with a high mean systemic pressure. They inspire. Their right atrial pressure drops, but it doesn't drop enough to drop below intra-abdominal pressure, and so you actually do not see collapse here. Okay? As dialysis proceeds, this patient now becomes quote-unquote euvolemic. Okay? As a result, their right atrial pressure drops. So now when this patient inspires, their right atrial pressure continues to drop, but now it's actually fallen below, significantly below, the increase in intra-abdominal pressure, and you actually start to get this fluttering effect. Okay? Now the patient continues dialysis and actually gets a little hypovolemic. Well, now when this patient inspires, they clearly have collapse of the IVC. Okay? But consider a similar patient, hypovolemic, with a depressed cardiac function. Well, for the same inspiratory effort at all 3 volume states, the patient will not, or maybe only partially, display collapse of the IVC. So this patient inspires. In this situation, right atrial pressure in the hypervolemic state, watch that again, the patient goes from here to here. There's a minimal drop in right atrial pressure, so certainly not enough to cause collapse of the IVC. It's nowhere near the collapsing segment of the venous return curve. And this patient is hypervolemic. That makes sense. This patient is euvolemic. There's minimal decrease in right atrial pressure with inspiration, and therefore the minimal decrease in right atrial pressure retards collapsing of the IVC as the rise in intra-abdominal pressure cannot supersede the drop in right atrial pressure. And then even in the hypovolemic patient, you may actually not lower your right atrial pressure enough to cause the abdominal collapse, or to lead to a pressure gradient between the IVC and the abdominal pressure to lead to IVC collapse. And you can see that the reason this is because cardiac function is depressed. And if your right ventricle cannot pump blood through the pulmonary circuit that well, even if you're hypovolemic and you don't have you've got a diminished venous return because your volume status is low and your mean systemic filling pressure is low. So even though you've got less blood returning to the right heart, because the right heart cannot adequately pump it forward, the pressure within the right atrium and the right ventricle remains relatively high. And so even when you inspire and drive that pressure down, it still does not lower enough below abdominal pressure, and you do not see collapse of this hypovolemic patient. Okay. What does that tell you about volume status? Not much. What does it tell you about volume responsiveness? Not much. It's certainly a contentious subject. Sheldon Magder has shown that the best predictor here is a lack of drop in right atrial pressure is good at predicting patients who are not fluid responsive. If the right atrial pressure does drop with inspiration, it's fairly well at predicting volume responsiveness. But that being said, in a recent study by Heenan and colleagues in critical care medicine, they found that inspiratory changes in right atrial pressure had actually no bearing on predicting volume responsiveness. So in this patient, I talk about how this graphic simplifies things somewhat. The active inspiration, as I alluded to before, can change the slope of the cardiac function and venous return curve. So if this patient makes a forced inspiration, you may actually change the venous return curve as the diaphragm descends, pressurizes the abdomen, increases mean systemic filling pressure, but you actually at the same time increase the resistance to venous return as the diaphragm descends, and you make a significant inspiratory effort. You can actually see collapse of the IVC in this situation, but again, this is your starting point. This patient is not going to be terribly volume responsive. They may be euvolemic, and then they make an exaggerated inspiratory effort. You'll see IVC collapse, but it doesn't tell you about their volume status or whether or not they're volume responsive. And then in Chapter 8, I end with probably the best, definitely the best dynamic marker of volume responsiveness, and that's the passive leg raising maneuver, and that's because this maneuver has been well validated in both patients passive with the mechanical ventilator and generating inspiratory efforts on the ventilator and completely spontaneously breathing. And that's because the passive leg raise stresses the cardiovascular response not by a change in intrathoracic pressure, but by actually increasing venous return by recruiting blood volume from the lower extremities. So the passive leg raise is simply the patient should be in a semi-recumbent position. You then lay them flat and then also at the same time raise the legs, and you should do this and measure instantaneous cardiac output by descending Doppler flow. Pulse pressure variation, stroke volume variation has not been proven to be adequate when doing the passive leg raise. You actually need some form of Doppler flow, whether a transthoracic aortic outflow VTI or a descending aortic esophageal Doppler, doesn't matter. But those will work in the patient who's making inspiratory efforts. And the important caveats to this test is that you need to minimize pain during passive leg raising to prevent sympathetically induced cardiac output augmentation. Compression stockings should be removed. You should try to attempt and confirm that preload has actually increased during the passive leg raise, for example, an increase in CVP or pulmonary artery occlusion pressure or left ventricular end diastolic area, to minimize false negatives, because if you don't recruit enough blood from the lower extremities, you may call that a negative result, but that doesn't mean that the patient is truly not volume responsive. Clearly, it should be avoided in situations where you want to minimize increases in ICP, and intra-abdominal hypertension may retard venous return from the lower extremities. So that was it for my intro to Chapter 8. Thanks for tuning in. If you haven't already watched the long version of the lectures, please do so. Maybe it'll clear up some of the confusion that you've had in these overview sections. Hopefully it will stimulate more interest and a bedside appreciation for the physiology in the critically ill patient. Thank you very much.